Welcome to part 3 of Open Anesthesia's July 2024 Focus Case of the Month. If you have not already watched parts 1 and 2, I encourage you to do so before watching this video. As a refresher, our case involves a 77-year-old woman who is scheduled for a mandibular fracture repair under general anesthesia requiring nasotracheal intubation. Her past medical history includes Parkinson's disease, dementia, and type 2 diabetes. Her past surgical history includes a colonoscopy and hip arthroplasty. The patient is currently on several medications including carbidopa, levodopa, donepezil, and metformin. Regarding her NPO status, the patient reports consuming breakfast 3 hours before presentation. However, her caregiver reports that she has been NPO for over 6 hours. Due to this discrepancy and the uncertainty about the contents of her stomach, a gastric ultrasound is performed to assist with anesthetic planning. To organize our discussion of the gastric ultrasound exam, we have been using the IAIM framework: indication, image acquisition, interpretation, and medical decision making. Interpretation. The focused gastric ultrasound exam sought to answer 4 questions. Let's now recap the answers to those questions for our patient. For our patient's gastric ultrasound exam, the best answers were: 1. With the patient supine, the gastric antrum appears distended with thick fluid or solid content. 2. Given the findings of a full stomach in the supine position, placing the patient in the right lateral decubitus position is not indicated. 3. A gastric volume estimate is not indicated for solid content. And finally, 4. The overall sonographic impression is that of a full stomach. Now, how would you use the gastric ultrasound exam findings to optimize the management of this patient's anesthetic care? Given the gastric ultrasound findings, which of the following steps would be the most appropriate? Multiple answers are acceptable here. A. Proceed with anesthesia without any additional precautions. B. Delay the procedure and re-evaluate the patient after a longer fasting period. Or C. Proceed with surgery, use rapid sequence induction given the gastric ultrasound findings. Of the choices listed, the most appropriate steps would be to delay the procedure and re-evaluate the patient after a longer fasting period. If the decision is made to proceed with the procedure, despite the full stomach, the patient would require a rapid sequence intubation to secure the airway, along with a discussion with the patient and their family regarding the increased risk of aspiration. In addition to identifying the fasting state, gastric ultrasound can be used to confirm the placement of a nasogastric or NG tube. Studies show that ultrasound confirmation of NG tube placement is feasible in almost 90% of the patients in acute care settings. Furthermore, ultrasound has shown a sensitivity of 93% and a specificity of 97% for confirming NG tube placement compared to chest radiograph. To confirm NG tube placement using ultrasound, follow these steps. Step 1. Probe positioning. Place a low-frequency probe just caudal to the xiphoid process in the mid-sagittal plane. Ensure the probe indicator is pointing cranially. Step 2. Image acquisition. Obtain clear images of the gastric antrum and surrounding structures. Step 3. Confirmation of placement. Finally, the NG tube often appears as a hyperechoic or bright linear structure within the stomach. On ultrasound examination, the nasogastric tube can be visualized as 2 hyperechoic or bright parallel lines as indicated by the blue arrow in the image. If the NG tube is not visualized in this manner, an air-water admixture consisting of 10 cc of air and 40 cc of normal saline can be injected through the NG tube. This mixture creates dynamic fogging in the stomach at the tip of the NG tube, confirming its placement. Here we see a case of a patient presenting with bowel obstruction and a distended abdomen despite having a nasogastric tube in place, raising concern for a malpositioned NG tube. Ultrasound examination of this patient revealed a distended abdomen with the NG tube located in the stomach, which necessitated the placement of a new NG tube with subsequent successful decompression of the abdomen. Gastric ultrasound, while a valuable tool, has several limitations. Findings from a gastric ultrasound may be inconclusive in 2 to 3% of patients due to multiple factors: obesity, recent abdominal surgery, large hiatal hernia, and significant bowel gas can interfere with the quality of the ultrasound images, making it challenging to visualize the stomach and its contents. Additionally, gastric ultrasound is primarily effective in assessing the antrum and may not provide comprehensive visualization of the entire stomach. Pathologies or contents in other parts of the stomach might be missed. The presence of adjacent organs and structures, such as the liver, can sometimes obscure the view of the stomach and complicate the interpretation of ultrasound images. Despite these limitations, gastric ultrasound remains a powerful tool for assessing gastric contents and guiding clinical decision making, especially when performed by skilled operators in appropriate clinical settings. Here are the references we have cited in parts 1, 2, and 3 of this case presentation. Thank you for watching. If you have any feedback, please email us at info@openanesthesia.org.